My dear postgraduate students, thanks for your overwhelming support and encouragement towards the classes on autopsy. In today's class, we shall be dealing with incisions and thorax. The heading is a little strange. Let us see what it has got. Counting the chickens before they hatch. In other words, think of the subheadings. The subheadings will take you to the answer. So there are a number of these headings which are of great importance. I would not be repeating them. Kindly go through them. Half of them are related to the techniques, whereas the remaining two, the pathology per se, of the thorax and lungs. The autopsy tells us everything. John Pierce. The types of incisions. This I should have taken or would have taken in the last class, but I felt that this will be an apt moment. Name whatever alphabet you have got, you will be having an incision along with it. There can be an I-shaped incision, a T-shaped incision, a Y-shaped incision, a U-shaped incision. What are all these? We shall be seeing. Apart from that, there can be a sparing breast incision, or there can be an incision from the sternocleidomastoid along the costochondral region. I shall be showing you what it is. Limited autopsies are there. And also there can be a limited autopsy of the abdomen or thorax. Restricted autopsy is a different terminology. So for each of these, you have got different types of incisions. This is a definite question for you people in the autopsy exercise, in which answering is not important. Answering completely is. So do not blindly just say INT, but see what it is. So obviously you have to buy heart. These are the common autopsy incisions. Let us see this particular series of diagrams first and then this. There is a Y-shaped incision. Here, the incision is across the clavicle on either side. They meet at the manubrium sterni, and there is a straight incision to the symphysis pubis. There is another incision called a modified Y incision. Some books call them as U incision also. So it starts from behind the ear lobule and then across in the region of the sternum or manubrium sterni. It starts and then comes straight down, avoiding the umbilicus. This is a modified Y incision. This is the third and the conventional incision, the I-shaped incision, just a straight line from the symphysis mentae to the symphysis pubis, avoiding the or circumventing the umbilicus. So these are three different things. Now, why should you have so many different types of incisions? This diagram is almost the same as this, except this, in which I am finding it is starting from the acromion process and it goes below the breast, avoiding the nipple areola, etc. And it forms a wide U-shaped incision. Again, it meets at the sternum, avoids the umbilicus, comes down to the symphysis pubis. This is almost a corollary of this. We call it a U-shaped incision. Now, what are the advantages and the disadvantages of each of these? This will be of great importance because unless we know that, we will not be able to remember it. But once you know that, it is a child's play. The eye-shaped incision, for example, this is it. Umbilicus is left to the right, and the disadvantage here is the stitch will be visualized, particularly in the neck. You will be able to see the stitch. To avoid this, there is a Y-shaped incision from the acromion to the xiphisternum across the breast. And in this, the disadvantage is the neck structures will not be very clearly visualized. But there are no visible sutures. That is the advantage. Another disadvantage can be scarring across the breast. Some of us have got a big heart. I would like you people to go through the differences. The range is strange. So we will also be seeing the normal weight of the organs. So also the lungs. I find that it starts from as low as 640 and goes beyond 1000 grams. What are the conditions? What are the causes? We shall be seeing. And I will also be presenting you with the normal dimensions of the important organs at a later date. So again, the classical incision over here, obviously, there is no neck mark over here, but the visualization of the structures in this region might be difficult. After all, we will have to return the body in dignity. Once the incisions are over and the autopsies are over, there is also an examination of the back. Here, a spinal incision might be needed. This we shall be dealing later on, but please do remember there will be an incision posteriorly to visualize the spine. This is what I said as returned with dignity. Whatever be the incision, it will have to be sutured back. So much so that the body is returned to the relatives, the near and dear ones, as though they are seeing the person for the first time after death. So minimal trauma should be there or it should be avoided. The suture should be neat. You need not be a plastic surgeon, but then there has to be some dignity and decorum. The scalp on its part, it goes unnoticed because it is covered by hair in most cases. Finally, there has to be a decent burial. There are certain gadgets which are available for an artificial suturing also. But this is what is being followed in most of the autopsy centers. There are some sequential activities that are going on. After opening up, there is a ligature of the major blood vessels. This is for two reasons. One, to prevent the outpouring of blood, and two, to promote embalming or facilitate embalming. After the blood is evacuated to some extent, you find that the formalin or the buffered formalin is injected into it so that it perfuses into the various parts of the body, preserving it until it is autopsy. Also, you find that there has to be an examination of the neck and the floor of the mouth organs. Care should be taken in cases of strangulation because such a mark should be avoided. It is more for forensic pathology, but we also shall be having it in mind. Sometimes books such as Ludwig or even Langever, they recommend that the brain be removed earlier, so much so there is no pouring in of blood from the cerebral vessels into the neck also. These organs or regions can be avoided as much as possible unless wanted. This is a story of the Egyptian embalming, and you find that they are all driving away the evil spirits. That is why you find that the mummies have been preserved for centuries and centuries. It is not that they are all totally healthy. There have been cases of tuberculosis and other diseases diagnosed in those mummies. These are some of the incisions used for embalming. Either in the pubical region or in the femoral region. These are again the various techniques of removing. This particular chart is a summary of the different types of incisions. In this, I have mentioned the I, Y, U, and the modified Y incisions. And what is the region that is extending to? U, for example, it starts behind the ears or the collars. And in each one, what is the advantage or the disadvantage? In the I shape, we are seeing the suture in the neck, a disadvantage. In the Y shape, it is across the breast, therefore scarring will be there. In a U shape, you find that the breast is being avoided. But even in these cases, the spinal cord will have to be separately studied. The modified Y is there. And in all these, you find that there is a better exposure to the structures that are corresponding to it. Once there is an incision, you find that the skin is thrown as a flap onto the face and the dissection continues in the thorax and abdomen. This is incidentally the incision I had been mentioning. You find that it goes below the breast so that particularly when it is a female, there is no amount of scarring that is seen, at least from up to the breast. It is one organ that has to be treated with dignity. People very easily talk about a mastectomy or a radical mastectomy, throwing off everything. It is not the disease alone that matters. It is the psychological pain and trauma that the patient carries, even if you are going to cure her 100% of the malignancy. There are other incisions such as T for the thorax and T of the abdomen. In T of the thorax, you find that across from the shoulder to the shoulder, there is an incision, and down from there to the symphysis pubis. Whereas in the abdomen, you find it will be avoiding the umbilicus lower down, and then there is an incision on either side. These are used. So you people should be fluently mentioning the different types of incisions, what is a restricted autopsy, etc. So this again, I will not be mentioning this. You find that the entire section of organs are all being exposed. You find that they are no longer as soft and palpable as they are. You find that they are almost like a frozen shoulder or a frozen chest and abdomen. There are certain disadvantages. Now, for example, in a case of burns, you might not be finding the incision of the neck easy. So have these in mind. A genius, Vesalius, who exhumed the body and taught us anatomy. I like this word very much. So, Anton Chekhov. Beautiful. When performing an autopsy, even the most invertebrate spiritualist would have to question where the soul is. And what is the meaning of this one? Invertebrate. So, he is a person who believes something to the extreme. But even that person will have to search for the soul within the cadaver. That is what it means. These words are not important, but the dedication of the profession that they have got in them is to be appreciated. Sometimes on opening, you find that there is a thoracoscopy. So this can be when the patient is alive or at autopsy also. There is a lot of fibrous strands that is adhering the lung or the chest to the pleura. And this again, it is a case of bronchiectasis. I'm able to see the dilated channels down. But look at this. In the interlobar fissure, there is some amount of fibrosis that is being formed. Why this is mentioned is because once we open up, these are all certain subtle things that we will have to look for. Never be in a hurry to remove the organs en masse and put it for fixation. This is just a recollection. I know you people know all this. This is again a favorite diagram, anterior-posterior, and this probably a lateral or a sagittal view as such. So please do remember that there is a manubrium and then there is a sternum as such, and this is the xiphisternum. Fine. And there are the cartilaginous portions and the osseous portions of the ribs. And this is exactly called the chondro-osseous or osteochondrous junction. So this is important. And it is this particular region where they will be cutting with a rib cutter. And when you look at it laterally, it encompasses the entire viscera very snugly. The lungs as well as the heart within the pleura and lower down the diaphragm. Please have this in mind. Also, I'm able to see part of the trachea higher. Why am I showing you this? To have an idea about it. Because once we do open up, we should have an idea where the various organs are. So there is a esophagus that is posterior to the heart over here, and there is an aorta. And this is a lung in probably the mid-thoracic region behind which there is a vertebra. Have this in mind. And also these are the intercostal muscles that we should be having in mind, the cut surface of the ribs. How do you open the thorax? Once there is a incision, you find that the skin muscles are dissected and the intercostals are not damaged. You will have to test for a pneumothorax. How do you test for a pneumothorax? It is of paramount importance. Again, a question they will be asking you. You will have to open the portion underwater. You give a trauma without piercing the lung. And if there is going to be any bubble of air that is going to come out of it, it is indicative of a pneumothorax. I shall show you better pictures of it. You reflect the abdominal skin also. Sometimes the sternoclavicular joints are disarticulated. The rest of them are left as it is. There is another mode of incision. It starts from the lateral portion of the sternocleidomastoid. Sternocleidomastoid, you find it goes up to the mastoid region. The incision starts from there, comes straight down along the costochondral junction. And it done on either side, and you remove that particular flap of the rib cage. This is another incision which you people can memorize and answer. So it starts somewhere in the neck and then comes along the costochondral junction, and this entire rectangular piece is removed. Now, what are the procedures for preserving the lung? There is something called as wet preservation. Okay, put it in formalin or buffered formalin, it gets fixed. There is another thing called as dry fixation. You refrigerate it and then you try to embalm it. The third one can be a gaseous state. It can be a formalin vapor itself. And at the end of it, the lung has to be fixed in an inflated state. That is what we people are seeing in the museums. The dead are teaching the living. And it is being fixed with formaldehyde gas. So you find that the rib cage has been cut open along the costochondral junction, and these areas are particularly sharp. They can be traumatizing the prosector. I told you who the prosector is. He is the person who performs the autopsy. Also, we must see that there is no damage to the pleura or the pericardium. So remember the 4 P's: protect, prosector, pleura, pericardium. And these are the various equipment that can be used for opening the costochondral junction. This one is called as R.A.T.S. This is called as Wilson and Wilson, and this is Doyen. So these are different ones. Slowly and deliberately, you people should be knowing the names of the instruments, starting from the brain knife. Do not try to mug up everything at one stroke before the exam. We will be a very poor performer. After that, there is a blunt dissection. Blunt dissection is literally teasing. What you do is the skin and the subcutaneous tissue, it is being reflected without cutting through the skin. and without damaging the intercostal muscles. And after removing the rib cage or rather the costochondral junction, the chest contents are examined. Whether there is going to be any pneumothorax or an effusion, which is very important. And if that is so, it has to be taken for biochemical analysis. Sometimes we need it for cytological examination. Think of a bronchogenic carcinoma or rather tuberculosis or sometimes a mesothelioma. There is nothing wrong in taking an aspiration and doing a smear. But these, as we had mentioned earlier, should be done earlier. Rib shears are the instrument that I showed you earlier and how it is being removed. Injury to the prosector is avoided. And after all that is over, you find that along the jaw, you find that there is an arch in the lower mandible and that is being cut. And when that is cut, there is a reflection of the skin and the tongue is being exposed. You try to put in an incision and after that, we just get hold of the tongue and you pull it down. It is as though you are peeling the skin of a banana. It is almost as simple as that. And this is what we called as the Rokitansky's method, but then there is another name called the Luthel's method. So that is the correct name as it. This is the anterior-posterior view. This is the posterior-anterior view. The advantage of this method is we are able to see the relationship of the organs to each other, after which we will try to remove them. So when it comes to the trachea and the bronchi, it has to be removed in continuity with the lung. The heart, it is not possible because the aorta will be going behind. So what we do is we cut the great vessels as high up as possible. So much so, we are able to see any of the abnormalities such as early atherosclerosis or an aortic stenosis, pulmonary incompetence, so on and so forth. And the external viscera is also being examined. The pleura, for example, in this case it is transparent, but sometimes it can be thickened. So also the pericardium. And once it is being done, what we do is posteriorly, this will be the great vessel. I remove the tease out the aorta and the inferior vena cava. And they are reflected onto the abdominal side. These organs go on to the abdominal side, and behind the trachea, I'll be finding the esophagus that is being pulled down to the abdominal side. So I have got the abdominal organs in continuity with the esophagus, the thoracic organs in continuity with the aorta and the inferior vena cava, so that they have got some meaning. After which they are transected at the diaphragm. I've got separate thoracic organ, separate abdominal organs. Pelvic organs we'll see later. So this is the advantage of evisceration. The method, it has been described as sapphire. They tell you the truth, the organs, the viscera. Please listen. This is again, whenever the body is open, we'll have to look for certain things. Sometimes there can be a sudden cardiac death. So I find that there is a saddle embolus at this stage. So go to my classes on infarction, thrombosis, and embolism. What is the difference between an antemortem clot and a postmortem clot, etc.? You people will see. It is called an agonal thrombus. It will be causing an immediate death. And here again, I am able to see a large thrombus occluding a vessel. And this is again a case of a thrombus done in autopsy specimen. There is a section and it is showing recanalization. This is obviously the infarct that we see, a wet infarct or a red infarct that is seen over here. The reasons and all is different. Why I am showing this particular picture is there are different pictures related to the circulatory system, related to the lungs. So please try to have them in mind because the examiners will be passing on from one question to another, but they will be very intricately linked. We should not be taken aback. Thanks to this one, Journal of the Academy of Echocardiography. Beautiful. And this is a case of a this is a lung over here, it is normal. There is a ballooning over here. That is because Around the heart, there is a pericardial effusion that is separating both the lungs. They are being separated over here, and finally it is being removed. It is a fetal autopsy wherein there is a massive pericardial effusion. Look at this picture, a barrel-shaped chest, diagnostic of emphysema. There are certain specimens which might go hand in hand with autopsy. Go to Robbins, he would have described the various things, feathery to feel, pillowy to touch, so on and so forth. Please do read it. But then admire this. I hope you people are convinced with the barrel-shaped chest. So near and yet so far. So that is how you find that the circulatory system and the respiratory system are closely intertwined but then widely separate. I hope you people are able to recall the various structures, the arch of the aorta, the major branches, the trachea, the main bronchi, and so on. This particular picture is of great importance because we will be teasing it over here so as to separate the trachea from the esophagus. The esophagus goes into the abdomen and the trachea remains in the thorax. So also you find great vessels are reflected onto the thorax. But what is important is this particular region, we will have to look for any trauma, malignancy, or sometimes a tracheoesophageal fistula. So I hope this explains everything. There is the trachea and then the bifurcation over here. There is an arch of the aorta. There is a esophagus over here going into the abdomen, stomach. So obviously this reflection is important for us. This is how it will actually be cut, because beyond this, it will not be possible for us to take the aorta in continuity. So that itself will be an ordeal, and then we'll have to sacrifice the cadaver for it. The list of instruments just for conditioning you people. We shall revisit them later. In this particular class, I shall be restricting, or rather series of classes, I'll be restricting myself to the lung. So this is a beautiful picture from Ludwig. And this is a lung. What happens is he has cut them as slices of bread. And they are all intact at the region of the hilum. So the lung can be reflected or turned as pages of a book. This is of great importance. The continuity will have to be maintained. There are certain other difficult exercises not given to us nowadays. Tracheobronchial tree, display it. So that is of great difficulty. That is not there for the students today. And this again, what I had mentioned, I am able to see a tracheoesophageal fistula. Thanks to Ludwig's text, you find the pictures over there. Lung perfusion. Even I was of the opinion that it is done only to inflate and then to preserve. But it is also done in another condition, namely for transplantation. In fact, that is more important nowadays. I would like you people to kindly remember. So there is a very sterile system in which there is an inflation that is going into the lungs, and this is the apparatus. Sometimes we have a series of apparatus for it, wherein the perfusion and the inflation are done. So it can be for transplantation. It can also be for autopsy for us, rather after autopsy. Deflation and inflation are not restricted to ego. It is life and death. And here again, it is a similar one. This is a lung that has been removed from the cadaver. And after that, at autopsy, you find that there is a reperfusion that has been done. Look at the massive change. And this is looking almost like normal. I won't agree that the patient does not. This is the reflection that I had been talking about earlier. So these are the ribs that I'm seeing, and there's a skin that is being reflected, and it has to be teased. Sometimes we'll have to look for any of the effusion, if at all we do suspect. See how beautifully it is being done, and all the intercostal muscles are being retained intact. So this is the multiple step perfusion that has been recommended by Ludwig. This particular picture is of paramount importance. Look at the length of the knife. So it is almost longer than a brain knife. And the moral of the story is whenever we cut an organ, it has to be a single, deliberate movement in one direction. It should not be a seesaw movement. And this has been done so as to displace from the pleura right to the hilum. I'll be able to see everything. Similarly, it can be cut as pages of a book. That is one thing. Please also note that there is a wooden plank over here. So there is a cork groove. There is a board over here. This will give the kind of a friction and a thing. So it does not slip under that. And also, whenever you cut or wash, there will be the fluid that is accumulating, which is collected in a steel. So obviously, there is no, just like merchant of Venice, not a drop of it is spilling over outside. So this is the Herd method, capital H-E-A-R-D. That is that. He is a person who has deciphered the method of storing the lung. So it can be stored in the refrigerator. These are all the temperatures and other things. They can be sliced, and a formalin solution or a buffered formalin is being used. Several slices can be stored in a stack. And this incidentally is one such slice of lung tissue wherein I am able to find. Sometimes you find very thin sections can be cut by means of a Guff Wentworth section. It is a kind of microtome, a sledge microtome, wherein you can get a very large section. We have got such sections displayed at the entrance of the museum in Japan. So there is some amount of bronchiectasis over here, and there is also an increase in the air spaces, probably a combined emphysema also. Lobes and segments. You need not be as perfect as an anatomist. Look at the right lung over here, left lung. Right. Remember the letter R. So there will be 3 lobes. So you have got an upper lobe, middle, and the inferior. There is an oblique fissure for both, the left and the right. So there is an oblique fissure. This is the right lung and this is the left lung. And there is a small slit-like space over here. That is called the horizontal fissure that is dividing the lung into 3 lobes over here on the right side. So right is 3. R is, you have, in 2 you do not have the letter R. And this may be complete or it may be incomplete, this particular fissure. Other things I am not going to describe it as pinkish, okay, well, appears very healthy. And this is a single oblique fissure that is seen on the left lobe. Sometimes there can be an additional projection called the caudate lobe that is seen over here. And as I had been mentioning earlier, you can have a pneumothorax. Sometimes, in this case, there is an accumulation of blood, which we call a hemothorax. When there is going to be an accumulation of pus, it can be a pyothorax, or sometimes it is empyema when it is localized. Okay, liver is over here, the diaphragm, and there is a stasis of blood in this region. So the lung is not normal as such. I am finding that there is some kind of ballooning and it appears inflated, though not very large as a balloon. So it can be a partial or a surgical emphysema that is here. And this again, it is an emphysema that is spreading to the periphery. It can be a panacinar emphysema. Centriacinar emphysema, you will be finding multiple localized areas of expansion along with anthracotic pigmentation. Periphery will appear normal. So these are classical sections which can be cut by means of the Guff Wentworth sections. This is what I said. This is the water seal drainage. So whenever there is a lung over here and then there is an effusion, it can be collected by means of this. So there is a pressure over here, owing to which you find that there is a negative pressure, the fluid accumulates over here and the airway is closed. So Pleural effusion, it can be managed in this way also. Courtesy is CCF Pancreas. Pancreas is the person who has drawn this picture. Beautiful. Pneumothorax is one. We had already explained this one. In this, there is an accumulation of air and then there is almost a collapse of the lung also. So definitely an undersea drainage or underwater drainage has to be done in this case. Now coming to this pneumothorax, before I complete, remember, it can be a closed pneumothorax. So you find that from the lung, the air is entering into the pleural cavity, it is getting accumulated. Or it can be an open pneumothorax from the exterior. If there is going to be a stab injury, etc., or sometimes a fracture of a rib, you find that air can be entering inside. Third one is a tension pneumothorax. You find it keeps accumulating in one region, collapsing the lung. All of these can be medical or surgical emergencies. Please do remember the different terms of pneumothorax, at least for the sake of completion. And courtesy NetMeds for these pictures. So this again is a beautiful case of empyema. I would appreciate Professor Langever because this was what he was demonstrating to us. And when he had done an autopsy on a HIV cadaver, he saw the pus and he was thrilled with it. Definitely it is a case of HIV, he said, and it was so. We did perform an autopsy, but the cause of death was inconclusive, pending further microscopic and toxicology tests, which might take anywhere between 6 to 8 weeks. The usual story that the pathologists give. And always we used to say, when in doubt with any of the diagnosis, keep it for fixation. To be continued. Thank you.